All right. So thank you all for coming. Let me introduce myself. My name is Paqui Paredes. I'm the Dean of the College of Humanities and Social Sciences at Western. And I'm here to introduce the speaker to our Fall Dean's Lecture Series. And our speaker is Dr. Douglas Sladen. And let me get my cheat sheet because I have a lot of things that I need to tell you about him. So Dr. Douglas Sladen is an assistant professor in the Department of Communication Sciences and Disorders at Western. Dr. Sladen has built his career as a clinician, scientist, mentor, and professor. He received his master's degree in audiology from Western Washington University in 1994, and his PhD from Vanderbilt University in 2006. And he started as an assistant professor at Western in fall 2017, so just last year. So in a lot of ways, it's been coming back home for him, and very good luck for us. So we're very glad that you're back here, Doug. Dr. Sladen has a special interest in the auditory system and works towards minimizing the negative effects of hearing loss. Specifically, his research is focused on the speech perception abilities of adults and children with cochlear implants, an auditory prosthetic used for cases of severe hearing loss. Most recently, he has been studying cochlear implantation as a treatment option for single-sided or unilateral hearing loss. Since arriving at Western Washington University, he has started a new cochlear implant program that offers clinical services to the local community. He is also building a research program that will continue his exploration into the role of auditory prosthetics. He has given over 50 conference presentations and invited talks in venues both national and international, and he has published over 30 papers in peer-reviewed journals, and he has also contributed invited chapters to a wealth of books. So it is my great pleasure to introduce you to Doug Sladen, who is going to present to us today Adult Onset Hearing Loss, Emerging Trends and Technologies. Thank you, Doug, for sharing your wisdom with us. And before I sit myself, I have already done it. I'm going to charge you with checking that your cell phones are off. Or at least in silence, and we'll have some time at the end for questions. So as he talks, and you know, your mind is willing with questions, just keep them all in there, and you can ask them at the end. Thank you.
Thank you for the kind introduction. That was very nice. I appreciate the nice words. And thank you everyone for coming. I think I have some fun information to share with you today. In conceptualizing this talk, I really wanted to pull together a breadth of information that will be informative for you no matter what your hearing status, whether you have hearing that's typical or you have hearing loss that's mild or severe or one side or both sides. So thanks so much for coming. A little bit, so first, my disclosures. I have no proprietary interest in any of the materials or products that I'm going to present to you tonight. This is my only gig. I don't have any other side gigs. A little bit about me. I am from a small town in British Columbia. I'm Canadian, and my town is called Vernon. It's about 4 hours northeast of Vancouver, and historically it was known for its apple production. In fact, I'd say that the apple production in BC actually rivaled that in Washington State. So some really good produce. In the last couple of decades, however, those apple orchards have turned over into vineyards. Because of the gently sloping hills in British Columbia, and specifically in the Okanagan Valley, and the very intense and hot summers, it makes it the perfect place to grow grapes. In fact, there are now over 72 wineries in the valley where I'm from. So I'm going to suggest that if you're considering a wine tour, you go north to Canada. The Okanagan Valley is also home of this fun Loch Ness type monster. It is called the Ogopogo. It lives in Okanagan Lake. And if you're lucky, during your wine tour, you might spot one of these things in our lakes. I jest, of course, that's complete urban myth. I am also married to this fellow here. This is Dr. Steve Bennett. He works in human health and development. We have 2 children, boy-girl twins named Sawyer and Reese. They are now 2 years old. They are exhausting. So if I look foggy in the face, then that's the reason why. So tonight, I hope to take you down a little journey. I want to review with you the auditory system and how it works. I'm going to share with you some really important and new data about hearing loss and its emergence in the US and worldwide. And then I'm going to propose some possible solutions to adult onset hearing loss, including some new developments in pharmaceuticals, in hearing aids, and then also in my area, which is in cochlear implants. This will be review for many of you. This is a picture of our auditory system. And what you see are 3 main pieces, the outer ear, the middle ear, and the inner ear. As sound travels down the ear canal, it hits that eardrum, also called the tympanic membrane, and it causes it to vibrate. And those vibrations then move down the middle ear bones to the inner ear. And when it reaches the inner ear, those bones move in and out, and they displace some fluid inside that inner ear, or that snail-like structure. And that displacement of fluid causes tiny little hair cells to move in response. Those create an electrochemical response that is then sent to the auditory nerve and sent up to the brain to be processed as sound. So it's a remarkable amount of activity that occurs real time. There's no delay in between what I'm saying and what you're hearing. So it's a pretty complex system. So I would propose to you that hearing is a passive activity. It's something that happens no matter what I'm doing. As I'm standing up here, I can hear some typing going on over here. I can hear the computer. I can hear some people in the hallway. And that activity doesn't cease. It happens no matter what I'm doing, even when I'm sleeping. Auditory processing, on the other hand, is something that requires my attention and cognitive resources to hear the sound and then process it and assign linguistic meaning to it to code it as speech. So I would say that human communication is a complex activity that requires proficient auditory structures and function, proficient speech and language abilities, and then also cognitive functions like attention and memory. So when thinking about human communication, I like to use this model that was proposed by Denz and Pinson. And I like this so much because it really captures all of the elements that go into understanding speech. The first thing that we need is a speaker. We need someone to formulate an idea and send that information down to their articulators, their mouth, their lips, their jaw, their diaphragm, and to produce an utterance. And that utterance needs to move through the air and be received at a listener. That listener then has their auditory system to take the information up to their brain and process sound. Now here I'm going to pause and add a couple of arrows. There is sound going up to the brain and being processed, but the brain is also involved here. The amount of knowledge that I have, my vocabulary, my language proficiency, all of that adds to my ability to understand speech, especially in difficult conditions like when there's distance or echoes or ambient noise. So how well I fill in the gaps when pieces are missing is dependent on what I bring to the environment. When we measure hearing, we plot it on a graph that's called an audiogram. And the audiogram has pitch along one axis, which is also shown in frequency or hertz or cycles per second. And we have loudness down another axis, going from very soft sounds up to loud sounds. And we test these pitches during a hearing assessment because we want to know how well a person can hear this range, because this is where the majority of our speech sounds fall. They tend to fall between 250 and 4,000 hertz. So in order to understand how hearing loss affects somebody's ability to process speech, we need to know how well you can hear those different pitches. So let's listen to a couple. This is a 250 hertz tone. This is 500 hertz. This is 1,000. This is 2,000. And this is 4,000. Now, if any of you were expecting to hear that and you didn't, then we should have a conversation following the talk. Now, hearing loss in adulthood is a growing issue for us. And it's a growing issue because it tends to occur as we age. According to the World Health Organization, there are now 466 million people with hearing loss worldwide. And in the US, we know that age-related hearing loss tends to occur around the 4th decade of life, so I'm now well into mine, and it is the 3rd most common disorder amongst older adults. That's becoming an issue for us because we are a society that is becoming comprised of older adults. There are now approximately 40 million Americans who are over 65 years of age, and that number is expected to increase by 147% by the year 2050. So we as a society and as an audiology profession need to figure out how we're going to manage this. How are we going to manage the number of people that need audiology services and who need some form of remediation for that hearing loss? Hearing loss as we age is characterized by a decrease in hearing sensitivity that occurs in both ears. And unique to age-related hearing loss, those people have a very difficult time understanding speech, even when we amplify it and make it audible. In addition, noise is especially problematic for older adults. Compared to younger adults with hearing loss, older adults have a more difficult time understanding speech and noise. So whatever our solutions are, they need to address the unique characterizations of adult-related hearing loss. This is some classic work in our area put out by Gates and all in 1990, where they looked at 1,662 men and women, and they measured their hearing at different age brackets. So between 65 and 70, 70 to 75, 75 and 80, 80, 84, 85 to 89. And what you see is that as we move from low to high pitch, the hearing gets worse. And it's worse for older adults than the younger adults. Finally, it's worse amongst men than it is for women. On average, we lose about 1 dB per year after we pass the age of 65. Now, what happens to our hearing system as we age? Well, there are many structural changes, but one of the most pivotal changes that happens is a loss of those tiny hair cells that I mentioned, the ones that exist in the inner ear. This is some lovely photomicroscopy work by Dr. David Furness, and what we see is a typical inner ear with thousands of little hair cells, and then we see the inner ear that is of an aged mouse. So this is an animal model which has been aged and then examined to see what their inner ear looks like. And what you see is that all those hair cells have decreased in number, and some of them have fused and some of them are bent over. They're certainly not looking as healthy and standing upright as a younger model. The amount of age-related hearing loss that we experience is a compound effect of our genetics. So did your parents or your siblings have hearing loss? Environmental factors like how many rock concerts did you go to and how did you protect your hearing? and then how many toxins you were exposed to. So certain medications can be toxic to our ears, and all of that can play together and affect how much hearing loss we have as we age. So everyone's a little bit different and is really a unique reflection of your environmental factors. In the last decade, there's been some surprising new work looking at age-related hearing loss and cognitive decline. And this is important to us because we want to understand what this looks like. In several studies now, they have repeated these findings and found that there is a link between hearing loss in adulthood and cognitive decline. Now, what is not known is the nature of the relationship. We don't know if one precludes the other or if one begins before the other. We don't know if they all occur at the same rate or if they are interacting with each other. What we do know is that if we fit people with hearing aids, there is no consensus on how that changes cognitive decline. So some studies suggest that if you fit hearing aids early in life, you might avoid cognitive decline, whereas others do not show that. So whatever the relationship is complex and is not uniform. There is limited data looking at people with cochlear implants, a large-scale study from France, and in that study, they showed that people that were fitted with cochlear implants had improved cognitive performance 1 year afterwards. Now, there's some problems with that data. It may be simply that they were able to hear the instructions better, or it may be that restoring audibility does something to our cognitive skills. But still, we really don't understand what the nature of this relationship is. So I'm painting a negative picture of our aging process, but I want to reassure you, it's not all downhill. So we do know that as we age, our working memory goes down, our processing speed goes down, we have limited divided attention skills, but there are some things that go up. Our vocabulary goes up. Our vocabulary increases as we age. We have more world knowledge. And I'm saying we because I'm including myself in this category. And we have more expertise. And remember what I told you about the brain and our hearing system. Our brain plays an important role in this. What we know is important for filling in the gaps. So when hearing loss starts to occur, we're able to fill in those gaps effectively. To demonstrate this point, I'm going to show you this graph by Timothy Salthouse. This was some lovely work that he did looking at what happens with vocabulary, processing speed, and then more cognitive factors like reasoning and memory. On this axis, we see chronological age going from 10 up to 90, and on the y-axis, we see performance. What you see is that processing speed goes down, but that vocabulary goes up. I fall right about here. So I'm expecting my processing speed to go down, but I'm getting a really, really large vocabulary. So I feel okay about this. There's a trade-off. Okay, so what can we do about this? What are some options for remediating adult onset hearing loss? There is now emerging evidence both with pharmaceuticals, so with drugs that would treat hearing loss, with new forms of hearing aids, and then also with cochlear implants. So let's spend a little bit of time talking about these. Pharmaceuticals. There are a number of people who are much smarter than I am working on this problem, trying to figure out, is there something that we can do to A, regrow damaged hair cells, or B, prevent the decline of hair cells? So independent researchers are working on this, and pharmaceutical companies are also working on this. Remember, I told you that there's a growing number of adults in our world, and hearing loss is the third most common disorder. So there's a lot to be learned and perhaps money to be made for people that develop the right drug to treat hearing loss. The first option is stem cell therapy. Stem cell therapy is based on the idea that we can introduce stem cells to a diseased or disordered cochlea and have those stem cells grow into new hair cells to replace the ones that we've lost, the ones that are damaged. We can use what's called a pluripotent stem cell, which is a stem cell that has been modified through our own cells to be a newly formed stem cell. So it doesn't have to come from an umbilical cord or from stem cells gathered at birth, but it can be stem cells that are created from your own cells. We could also try gene therapy. Gene therapy is specific for people that have a genetic-related hearing loss, so things like Usher syndrome. Now, gene therapy is meant to be targeted towards defective genes. If we can devise a drug that can replace that defective gene, then that gene won't be expressed, and then the disorder won't be experienced. At present, there are no human trials looking at stem cell therapy or gene therapy. There has been work in petri dishes and animal models, and some researchers have been able to regrow hair cells, but they didn't function. So they were standing up, but they didn't work right. So we're a long ways off from any sort of human trials with stem cells or gene therapy. Molecular therapy is the idea that we can develop a drug molecule to be introduced to the inner ear to protect it from the negative effects of noise or toxicity or aging. In fact, this study by Brock and colleagues from June of 2018 is the first to show that these protective agents can work in cases where there is toxicity to the ear. In this study, they took 109 children that had hepatoblastoma, which is a form of liver cancer, and they divided the children into two groups. The first group of children received cisplatin as a form of chemotherapy, and the second group received cisplatin and also sodium thiosulfate. They received the sodium thiosulfate 6 hours after they received their cisplatin therapy. On this side of the slide, you can see some outcomes. And I'll direct your attention to the first set of bars. This is the number of children who had no hearing loss at the end of the trial. And what you see is that the children who received sodium thiosulfate were greater in number than the children who received cisplatin alone. So arguably, the administration of the drug protected their hearing from the negative effects of the toxic agent. This next set of bars shows the number of children that did have hearing loss. But what we see is that the number of children in each group that received sodium thiosulfate was less than the children who received cisplatin alone. So this study shows us that the administration of sodium thiosulfate is significantly protective against the negative effects of chemotherapy. We did a similar study on a drug that was meant for age-related hearing loss. Sadly, we found that there was no effect. So there are emerging studies in this area to show that molecular therapies can be used as protective agents. Okay, so I'm telling you that drug therapies and stem cell therapies are probably a ways off from being proven as very efficient. So what is available now for you to take advantage if you're starting to experience age-related hearing loss? The first is hearing aids. Hearing aids have come a long way since the older analog hearing aids that my grandfather wore. The hearing aids today are pretty sophisticated. They have advanced digital signal processing, meaning that the sound is pretty clear. It's digitized into a series of ones and zeros and has a very clean sound to it. In addition, the noise suppression algorithms are pretty sophisticated today. A hearing aid can detect ambient noise levels in the background and push it down to improve how well you can hear speech above the background noise. The aesthetics are much better, so the hearing aids today are pretty small. They can fit behind your ear with a very thin tube that fits into your ear canal. And they also have Bluetooth technology. You can pair your hearing aids to your tablet or to your iPhone, and you can stream music from your devices right into your ears. The hearing aids that I'm showing up here can be Bluetooth so that you can answer a phone call through your hearing aids. So pretty fun stuff. Hearing aids are expensive, and so I want to offer an alternative. There are hearing aids that are provided direct to the consumer, or over-the-counter is a new classification of hearing aids that's coming in 2020. These devices are much less expensive than ones you can get from an audiologist. So some of these you can buy online, some of them you can buy at Walmart. They're not customized towards your ear, so they tend to provide amplification, but not as customized as you'd get from an audiologist. So there's a place for these, though. There's a place for these, especially when we think of accessibility for hearing aids that are so expensive. And that's important to us. We want everybody to benefit from amplified sound if they can, and providing access at a lower cost seems like a good idea to us. I want to be clear, though, our best studies, such as this one by Larry Humes and colleagues in 2017, our best studies show us that people benefit from these over-the-counter hearing aids, but the benefit isn't as large as you would have if you got those hearing aids from an audiologist. So those are important findings. They tell us that there's benefit to be had, and people can have better access to these lower-cost hearing aids, but their outcomes won't be as high as if they got them from an audiologist and had them custom fit to their ears. Okay, so let's move on to cochlear implants. Cochlear implants have been around for a while now. The first one was FDA approved in 1984. But the technology has exceeded all expectations. These devices work much better than we think they should, given the complexity of our auditory systems. A cochlear implant is comprised of two pieces. One piece is implanted under the skin. So on this part, we see a magnet that is used to retain the outside piece, an electronics package that's encased in titanium, and then a lead wire that goes down to an electrode array that goes into the inner ear. And by placing that electrode array in the inner ear, we're able to convey all those pitches that I showed you at the beginning, all the ones that are important for speech understanding. So these electrodes can bypass the level of dysfunction of the cochlea and stimulate the fibers of the auditory nerve directly. The piece that's worn on the outside is called a sound processor, and the sound processor has an electronics package, a battery, and then a transmitter that sits over top of the magnet. And that transmitter sends information across the skin on a radio frequency. That signal then powers up the internal piece and sends information down to the electrode array that stimulates those different parts of the nerve, of the auditory nerve fibers. And the outcomes are remarkable. This is some data that I collected a couple of years ago. These are 89 consecutively implanted adults who lost their hearing in life. And what I've done is I've plotted their pre-operative speech perception scores. So how well could they understand speech? What you're seeing are their abilities to understand single words and their abilities to understand sentences. So the stimulus might be something like, say the word ball, and the person would say back ball. Or the stimulus might be, the boy ran down the road, and the person has to say back, the boy ran down the road. In this graph, we see adults who are less than 60, those that are 60 to 69 years of age, those that are 70 to 79 years of age, and those that are 80 plus. All of these age groups were scoring at the bottom of this test. With their hearing aids on, they could not understand speech very well at all. These are their data 1 year after using a cochlear implant. And when I see these, I'm always struck by how profound the improvement in their performance is. What you see is that now, 1 year after using the device, adults on average, when we collapse across the age groups, are hearing words at about 67% correct, whereas before their surgery, they were only getting about 10% correct. Now, after a year of implant use, they're hearing sentences with about 80% accuracy, whereas before surgery, they're only getting about 15% accuracy. So the outcomes are remarkable. for speech understanding, and also for overall quality of life. And I'm going to share some of those data with you now. So because of the success with cochlear implants for people with severe bilateral hearing loss, over the last couple of years, we've done a number of studies looking at people who fell outside the current FDA guidelines. And what we found is that people who have less severe hearing loss also benefit, people with asymmetric hearing loss benefit, and shockingly, people with unilateral hearing loss also benefit. This is an important finding to us because unilateral hearing loss occurs at an alarming rate in our country. Sudden onset, idiopathic, meaning that there's no known cause, hearing loss occurs on one side in approximately 65,000 new cases every year. That means that people who are walking around with good hearing on both sides in 65,000 cases may wake up in the morning and not have any hearing on one ear. And there are no treatment options available to them. There are no drug therapies, there's no antibiotics, nothing that can restore that hearing. The only treatment option that is available are cochlear implants. Cochlear implants currently fall outside the FDA guidelines for people with unilateral hearing loss. So these next few studies we did were looking outside the FDA guidelines. In our first two studies, we showed significantly that people with unilateral hearing loss will benefit from a cochlear implant. But now I want to share with you some longitudinal data looking at a larger cohort of people. In these first few studies, we only had a small sample size, about 15 people, but we've improved that quite a bit. To participate in this study, people had to have a sudden onset hearing loss in one ear, a hearing loss that was present more than 6 months, but less than 2 years. We were working with adults and children who were hearing less than 50% of the words on the affected side. People that were excluded from the study were people that had known cognitive deficits or a hearing loss that affected the nerve or something above the nerve. So we were only looking at people that had a hearing loss in the cochlea. These data show 42 people who were implanted. 6 of them have withdrawn. 2 were lost to follow-up because they moved. 2 progressed to bilateral hearing loss and were no longer candidates for the study. 1 became a non-user because the person heard sounds that they didn't think lived up to their expectations. And then we had 1 failed device, meaning that the device was implanted, but then it didn't work. Unfortunately, that happens in cochlear implants. It's a piece of electronics, and like any other piece of electronics, it unfortunately can fail in some circumstances. To test their performance with an implant, we did several test measures. The first was their ability to hear in quiet. And again, we tested their ability to hear words and then also sentences. Then we tested their ability to hear in noise using a large array of speakers. And then finally, we tested health-related quality of life. And we used 3 measures of quality of life. One was a general health questionnaire called the SF-36. The SF-36 is used broadly in many domains, so not just cochlear implants, but in general health outcomes. Then we used 2 that were disease-specific, that were meant for people with hearing loss. The first was called the Speech, Spatial, and Hearing Questionnaire, and the second was called the Nijmegen because it was developed at the Nijmegen Institute. The test setup looked like this. So here's our array of speakers. There are 8 speakers that went in a 360-degree pattern. Noise came from all the speakers, but speech came just from in front. The participant would be seated in the middle of this speaker array and asked to respond to the sound using a keyboard and a monitor in front of them. We tested people preoperatively, and then at 3 months post-activation, 6 months post-activation, and 12 months post-activation. These data show people, the 36 people preoperatively, 32 at 3 months, 28 people at 6 months, and 20 people at 12 months. In this graph, we see the hearing loss for our participants. On the top, you see the hearing loss for the ear that was affected. And the average hearing loss is in this dark gray line. So the average hearing loss was down here around 85 down to 100, which is quite a bit of hearing loss. On the other side, they all had relatively good hearing. So these scores fell above 30 decibels, so pretty good hearing thresholds. Okay, so now on to some data points. On this graph, we see their scores for single words and sentences in the light gray and the dark gray. We see their scores at the preoperative test interval, 3 months post-activation, and then 6 and 12 months post-activation. And what you'll see is that before surgery, their hearing on the affected side was pretty low, much like it was with the group I just showed you. So they're scoring at the bottom of this test. At 3 months, however, their scores have jumped up significantly, both for single words and for sentences. And that performance continues to improve even out through 12 months of implant use, though the majority of improvement happens in the first 3 months after activation. So significant gains in the ability to hear speech. This graph shows the individual data from the points I just showed you. I like to show individual data because there's so much variance in this population. It's important for us to understand what the individual data actually look like. And what you see is the same trend, that preoperatively scores were pretty low, everybody got better, nobody got worse. The majority of improvement happened in the first 3 months and then tended to be a broader or a shallower slope after that. What I've done here is highlighted the children in blue and the adults in dark gray. And what strikes me about this emerging data is that the children are performing better, or at least these children are performing better than the rest of the adults. So these are early data, but they might suggest that there is something about a young brain and treating a young brain early and having superior outcomes. But again, these are emerging data, and we need to follow up with larger sample sizes. This graph shows us their speech understanding and noise. And what you see here is their performance with the device off, so listening just through their better ear. And with this data point, we see their performance with the device on. The data is suggesting an improved performance because they're hearing speech at a lower level in the presence of background noise. So in the presence of noise, they can hear it at a softer point. This is significant at the 0.03 significant level. And finally, onto the quality of life survey. I like quality of life survey because it taps into something we can't measure in our sound booths. It measures how well these people are functioning outside of our own test environments. This is the data from the SF-36, which is a measure of general health. And the reason it's important to do this measure is because we're looking at indications that go outside the current FDA guidelines. And when doing this, we want to make sure that we're providing benefit, but we also want to make sure that we're not introducing any harm. So on this general health survey, we found no difference between the preoperative interval and the 6-month post-activation test interval on all health domains. And that's exactly what we hope to find. We hoped that we were not having any sort of negative effect on their overall general health. This data graph shows us results from the Nijmegen Quality of Life Questionnaire. And again, the Nijmegen is disease-specific. It's meant for people with hearing loss. And what we see is that between the preoperative test interval and the 6-month post-activation interval, we see significant improvement in all domains of their health-related quality of life. And then finally, this graph shows us the speech, spatial, and qualities of hearing questionnaire. Here, people were asked to rate their hearing with their implant as somewhere along this scale. If it was at the bottom, that meant that their hearing was worse with their implant. If it's at the top, that means they're rating their hearing as much better with their implant. And what you see is that on all 3 domains, speech, spatial, and qualities of hearing, they're suggesting improved outcomes with their implant. And again, everybody got better. There were a couple people that stayed the same in qualities of hearing, but nobody got worse. So, in summary, and staying within my timeline, what we've found is that there is a growing number of adults with hearing loss in our country, and we need to figure this out so we can manage this growing number of people that are going to need audiology services and likely hearing aids or some form of remediation of that hearing loss. The relationship between cognitive decline and age-related hearing loss is been proven. Now, we need to understand what the nature of that relationship is. Is it working in one direction? Is it bidirectional? What exactly are the underlying mechanisms of those two declines? Drug therapies, they remain a possibility for the future, but they are not available today, and I don't foresee them being available in the near future. In other words, in the next 5 to 10 years. So people that are experiencing hearing loss now have options available to them in terms of hearing aids that are both fit by an audiologist or over the counter. Both devices work well. Hearing aids that are fit by an audiologist tend to outperform those that you get over the counter. And then finally, cochlear implants have been proven to be an effective treatment of severe hearing loss for many groups now. Groups that have bilateral hearing loss, asymmetric hearing loss, and now even unilateral hearing loss. And with that, I will conclude and take any questions that you have. Thank you.
So, Doug, I know you work at Western, and there's a clinic there, and I've had the good fortune to tour that clinic. Can you tell our audience what sort of services would be available if we have someone in our family who meets some of the description you've talked about, hearing loss, maybe they're missing conversations and so on? Is there anything that your clinic can do for them?
Yeah, absolutely. Thank you for the question. So the question was, what are the services that are available at Western Washington University? We have a hearing clinic that serves the community. So anybody with any form of hearing difficulty is welcome to contact us and make an appointment. So that could be a mild deficiency, it could be a significant deficiency, whether you're having some form of a sensation in your ears that you're just not sure about, if you're having tinnitus or ringing or decreased hearing sensitivity. So anybody who's having any sort of hearing problem is welcome to contact us for an appointment. We have a full range of services that include pediatrics, adults, balance assessments, hearing aids, cochlear implants. In addition, we also have a fully staffed speech and language clinic.
What could we expect? What could we expect to pay to come to the clinic? What's
another
the
good question?
range?
So what could we expect to pay at Western's Hearing and Speech Clinic? We are a no-fee service clinic. We do not charge insurance, and we do not charge a fee for any of our services. We are also a clinic that supports a speech and language pathology master's degree program and an undergraduate program and a doctor of audiology program. So we want to see people for a service to the community. We also want to see people because we are developing future clinicians, and we want to have a steady supply of people coming through our clinic to help train our new clinicians. Yeah, good questions. Thank you. Sure.
Thank you. I'd like to figure out how I can find the aid that best matches the need that I have. Mm-hmm. And I'm a bit concerned, and I don't know this for sure, but are audiologists tied to a given aid company? They sell aids for one company or another company, so you pick an audiologist, you're stuck with the aids that they happen to sell. How do you get to the aid that really meets your needs the best?
That's a great question. So the question was, how do you arrive at a hearing aid that meets your needs, especially in light of the idea that audiologists might be married or tied to a specific hearing aid company? So I think it's a great question for any audiologist you're going to work with. Which companies do you work with, and are you exclusive? Some audiologists work with lots of companies so that they have a breadth of choices ahead of them, whereas others only fit one specific brand, so they're only allowed or able to fit that specific brand. So that's a great question for anybody you work with to know what their constraints are.
Are there any studies been done like Consumer Reports would do to look at the performance and recommendations on aids for certain needs?
Yeah, there are a couple of really good websites that are, I think, helpful for deciding which hearing aids are most powerful in certain situations. There's one that's called Hearing Matters. It's a great resource. I can't think of any others that are consumer-based, though. Yeah. You're welcome.
How much of what you've said today applies to like bone induction types of hearing aids or other problems with the bones in the inner ear or something like that? Are there options that you haven't talked about that address those kinds of issues, or is all you can do for the things that have a problem with the cochlear?
Right, that's a great question. So what are the treatment options for people that have a problem with the middle ear or the bones of the middle ear? There are some great new advances in bone conduction devices. Historically, the bone conduction hearing aids were only ones that had an osseo-integrated screw, so you had to have a surgery to place a screw into your skull, and then you would snap in a bone oscillator. They now have ones that you use adhesive, and then you stick the bone oscillator onto the adhesive so it doesn't require a surgery. You can also get them in a headband form, so it's certainly worth looking into if you have a conductive hearing loss. There are some limiting factors. A bone oscillator can only go so fast, so it can only be so powerful. So if your hearing loss then starts to get very severe, then we might run into limits in which kind of bone conduction devices we can use.
Do you have experience with unilateral cochlear implant wearers feeling problems of being lopsided? One kind of sound coming in one ear, another kind coming in the other ear.
That's a great question. So do we run into people who are fit with one cochlear implant and then wear a hearing aid on the other ear and feeling lopsided, or maybe that the two signals are competing with each other? That's part of the beauty of our system. Our brain is remarkably plastic. And even though you have two different signals, your brain is able to successfully integrate those two signals. So that people who wear an implant on one side and a hearing aid on the other say that their hearing performance is best when they've got both ears going, and that the sound of the implant changes when they put their hearing aid on, which reflects how synergistic our two ears are. They're meant to work together. And the nerve from this side crosses over to this ear and vice versa. So the pathways intersect quite a bit, all the way up the brainstem to the cortex. So thankfully, people do not report any sort of conflict with those two ears. Yeah, great question.
I was wondering if you could explain how tinnitus or tinnitus, how did you pronounce it?
Tinnitus.
Tinnitus.
Yeah.
How that fits into all the different devices.
Yeah.
For instance, if you have a cochlear implant, are you bypassing that area of the ear so that you're not going to have that any longer? Is it going to disappear? I notice when I put my hearing aids on, it disappears for me. When I take them off, I definitely have it. So I'm just not sure how it's working together.
So the question was about tinnitus or tinnitus. It's really a potato type of deal. There's no right or wrong pronunciation. So tinnitus is the most common side or kind of byproduct of hearing loss. So people with hearing loss most often also have tinnitus, and it's likely due to damage in the inner ear. The problem is it's very variable, so that some people have the locus of the problem at the level of the inner ear. For some people, it's more along the auditory nerve or the brainstem. So treating tinnitus becomes really problematic because the source is probably variable across people. What we do see are some consistent findings that people that use hearing aids or cochlear implants will have a relief of their tinnitus when their devices are on. It's likely because the sound coming in is masking the tinnitus that you have. So if you have like a faint or even a moderately loud, high-pitched sound, when sound is being reintroduced, then it kind of masks it out. There's also a very strong relationship between tinnitus and our stress response. So when people hear tinnitus, they go, oh no, What is that? Is that a tumor? And the stress response makes the tinnitus worse, which makes them more stressed out. And it's this vicious cycle they get into. So a common behavioral technique to managing tinnitus is to relax, to reassure yourself that this is a common thing that occurs with people that have hearing loss, and there's nothing more serious than that. Yeah, good question. When tinnitus is so severe that people are depressed or need medications, there are other forms of treatment that are available to them. The problem is that there's not a whole lot of research showing that those treatments are effective. So it may be a bit of a fishing expedition to find out what works.
In that the hearing loss is in the elderly and there's often dementia that's associated with it, are there devices or treatments that can overcome the difficulty that some elderly folks have in wearing hearing aids as they lose cognitive ability?
So I want to understand your question correctly. So people that may have some early onset dementia, are there hearing aids that are better for them?
Well, I mean, I'm thinking of my father, who was no longer able to manage his hearing aids and wouldn't accept an aid, putting the hearing aid into his ear, or for that matter, his wife, my mother. So he was unable to use hearing aids because of the combination of hearing loss and dementia.
Yeah, right. So the question was about dementia and are there aids that are perhaps more acceptable or maybe more user-friendly for people that aren't going to accept their own hearing aids even when there's a long-term care aid there to help them with placement. In those cases, we might explore some of the over-the-counter or direct-to-consumer devices. So perhaps it's a headset that he would be willing to wear that has a microphone that goes to your lapel or your shirt, something to amplify your voice that doesn't necessarily have to come in the form of a hearing aid. Yeah, good question. Sir.
Doug, a lot of your data was from a sudden hearing loss. Mm-hmm. Is there data that shows when someone has had long-term hearing loss and then gets a cochlear implant, does the time to adjustment so that your brain kind of establishes those pathways again, does that take longer in those instances?
Yeah, good question. So the question was, does the adjustment to the implant take longer if you've had a longer period of auditory deprivation? So if you've had long-standing hearing loss, does it take you longer to ramp up or get acclimated? And the answer is generally yes. In studies looking at performance and acclimation to the device, we generally find that more than 25 years of auditory deprivation tends to have lower performance outcomes, and people tend to take longer to be able to hear well through their devices. And even once they've reached their ceiling performance, their scores tend to be lower than people that have a shorter duration of deafness. And what we think is happening is that as your ear is going unstimulated, that those pathways are losing their ability to transmit that information. And restoring hearing after such a long period of deprivation is not as successful. That being said, if I had a long duration of hearing loss, I would still seek a cochlear implant because the outcomes are still going to be positive, just not as high as they would for a shorter period of auditory deprivation. Yeah.
Yes, you mentioned at the beginning of your talk that toxins might cause hearing loss. Medicines, and I'm wondering if you could say more about what kinds. And along with that question, I was listening to a news story on hearing loss recently, and they mentioned people finding that their allergies were causing their hearing loss. And I'm just wondering if you could fit that in.
Sure. So the question was about toxic agents to our hearing system and what those look like, perhaps, and then also how do allergies play a part into our hearing system. So there are several very strong antibiotics that might be used to save a person's life that could also be toxic to the ears. So medications like vancomycin, gentamicin, even streptomycin are all known to be toxic to the ears. And then, of course, many chemotherapy agents like cisplatin and carboplatin are toxic to the ears. Accutane, which is a medication that's over-the-counter, Accutane is also toxic to the ears. Aspirin in really high doses can cause ringing in the ears. So there's certainly a whole host of over-the-counter medications that are toxic. Allergies can play a part in your hearing because if you have inflamed sinuses or inflamed tissue in the back of the throat, that can affect how well the tube that goes from the back of the throat to the middle ear can open up. If that tube can't open up very well, then you may get some recurrent middle ear dysfunction that can lead to ear infections and may cause some hearing loss too. So oftentimes when they're exploring people that have chronic ear infections, there's often a referral to an allergist to see if that's playing a part in that problem. Yeah.
So I'm afraid we have to wrap up the formal part of our program. However, I'm sure that Doug would be very happy to answer any questions that you might still have. For my part, I want to thank you for joining us this evening. It's always a very special day, the day of the Dean's Lecture Series, where we are down here instead of up on campus, and the community and the students and the faculty come together to learn about something that is important to us. So thank you all for coming. Thank you, Doug.
Thanks for having me. Thanks.